I'll be speaking to some of the lessons we have learned as we implemented the HIV self-testing project in Zambia. Being the last one on board, there are a lot of similarities to some of the presentations that we've just actually listened to, but I assure you there are some differences, so please keep your eyes wide open and your ears open as well to hear what we have to say. So a little bit of a background. So Zambia has a high HIV prevalence, but we've actually seen this prevalence dropping over the years. So currently 11.2, according to the revised DHS. We've actually seen an improvement in the testing rates as well, according to the DHSs. But it still needs some improvement because according to the last DHS in 2013, only 46% of women and 37% of men had tested in the previous 12 months and had received their results. So HIV self-testing is actually aimed to bridge this testing gap to reach the national goals for testing in line with the 1990 UNAIDS goal. So for the STAR project, the target was to distribute a little over 200,000 test kits over the 2-year period. And our target groups were largely the undiagnosed people living with HIV and populations that are at risk of acquiring HIV, and currently reaching those who are not reached with the conventional HIV testing strategies, including the males that we have heard about the whole morning. So the models that we implemented, we have 3 models. We have a facility-based model, a community-based model, and a VMMC model. So in the facility-based model, we use trained community volunteers who are placed at the health facility in an area that is actually decided upon with the health facility. So it largely outpatient department, but sometimes we are actually assigned to a different area. And this community volunteer distributes test kits within the facility, but also acts as a liaison for other community volunteers who are outside the facility, as well as for self-tests, for people who've actually undergone a self-test and are accessing services for post-testing. Then the community-based model also uses trained volunteers who distribute self-test kits to the general population, 16 years and above, using largely door-to-door methods, but also targeting certain hotspots, as we call them, such as marketplaces, churches, where you actually find large groups of people, as well as some sporting events. We've actually had some groups that go to football matches to distribute self-test kits. And the VMMC model aims to actually increase the uptake of VMMC after testing. So the model aims to distribute self-test kits to potential VMMC clients. So we use demand creation agents for VMMC who have already been doing work creating demand for VMMC, and add on top of that HIV self-test kit distribution. So all of this is done in the public sector. We're in 16 health facilities across 4 districts currently in Zambia, and all the 16 health facilities have a facility-based model and a community-based model, but only 5 of the facilities are implementing a VMMC model. Okay, so the famous linkage to care that we have looked at. So this is our cascade for Zambia, not too different from what we saw in Malawi. We have distributed a total of 96,000, a little over 96,000 test kits from the 1st of July up to the end of February. So 1st of July 2016 up to the end of February 2017. And of these, a little over 30% have actually returned the self-test kits to the designated points. And of the 31,000 returning the test kits, about 1,414, which is about 4.6% positive. So very low yield. And then of the ones who actually tested positive, only 192 actually were linked to care over the 6-week period that we actually look at when it comes to linkage. So when a test kit is actually distributed, we have a 6-week window period where we accept test kits back, after which we actually close the acceptance of the test kits. So I know we've spoken a lot about the low linkage, but I think I was actually encouraged earlier on, I think it was from the keynote speaker, who actually noted that in as much as people are not linking to care at a time that we think they actually should. By the mere fact that they know their status, they've actually taken the first step towards linking to care. So they may not link in the time that we actually think that they should be linking. And I think there's actually evidence, quite a lot of evidence out there that kind of underscores that people actually sometimes take long from the time they test to the time they actually reach a health center. So there are many behavioral issues that may go around that. But I think by the mere fact that they actually have tested and know their status, they are a step ahead from someone who actually hasn't tested. So as we move forward, I think in as much as we need to come up with strategies for improving linkages to care, I think we mustn't belabor the point a little bit too much in terms of being too worried that people are not actually linking to care. If they're testing, they've taken the first step. The yield also seems rather low, 4.6%. So questions are asked, what can actually be done to improve the yield? So perhaps more targeted distribution for people that we know may be at high risk is required. But I think even if the yield is actually quite low, as I said, people are testing, and if you know that you're negative, you should be then taking steps to actually remain negative. So monitoring and evaluation. Without data, it's very difficult to actually attribute how well the program is working. I know it's not very clear on this particular screen out here, but this is a schema that actually shows how our data flows. So we have all our distributors currently using tablets to collect data. We started off with a paper-based system and graduated to electronic data. By the end of December, all of our distributors were using tablets to collect data. And this is actually sent through to a server at the regional office, as well as to servers at the HQ. So we actually have the regional office being able to see the data at the same time that the HQ sees this data as it flows up. One of the lessons we have learned with this is when we started off with a paper-based system, there were a lot of missing data. So a distributor could actually opt not to tick one of the questions. And once the client is gone, it's very difficult to actually go back to them. So the electronic-based data collection actually improves the efficiency of data that is actually collected. And the other thing that we have learned in terms of monitoring and evaluation also is when we ask clients to actually report their experiences on their it's called a return test kit form, we get very interesting note from clients sometimes, unrelated to the questions that you ask. We actually have had people say, this is a wonderful program. They put a little note on the card, and then they do not answer any of the questions that you actually have asked them. So perhaps we do need to look into that, but I know literacy levels are one of the things that actually came up as to why people were not actually answering those questions, because the current form is actually all in English, so we do need to look into perhaps translating into the local languages. Some of the operational issues. So a phased approach actually allows for adjustment in implementation. We learn lessons as we go along. So our training has improved as we went along. We started off with 4 days, ended up with 6, because we saw 4 days was not actually sufficient. We have tweaked our data collecting form several times based on the information that was actually coming up from the ground. And a performance-based payment system for distributors is actually very important. At the very beginning of the program, there was a lot of concern that if we actually do a performance-based payment for the distributors that are giving out the kits, there may be indiscriminate distribution. But what happened is we had very motivated distributors who went flat out and did the work. And then the others knew that I'll be paid at the end of the month anyway, even if I just distribute just a few kits. So we actually saw some culprits where people were not doing their level best. So we have actually now switched to a performance-based system where you actually are paid for a certain number of test kits that you distribute. We have a continuous distribution model. So we are in these facilities. We've been in the facilities from the time they were trained last year. And one of the things that we noted is you need to actually define what your saturation point is, because you will reach a point where most people have actually either obtained a test kit or were previously tested and do not actually think they need a self-test kit. Our definition of saturation is if we reach 80% of the eligible population, which is 16 and above. And then you need to develop an exit strategy, what to actually do with that site once you reach saturation. It is important to actually do an adequate pipeline and forecasting for these for stock management, and I think we've done fairly well with that. And one of the things we have learned is when you actually store test kits at the facility level, when it comes to the regional level, you actually manage to ensure that the distributors do not run out of test kits because they're closer to them. Stakeholder engagement is very, very important, and I'm grateful the Minister of Health in Zambia is also here. They've been one of our key partners. We are implementing this in the public sector, so definitely they are a very key partner. So it's important to be able to identify who your key stakeholders are and engage with them early. And it's a continuous process. It's a new program. Not everybody actually buys into HIV self-testing. There's a lot of resistance from different sectors for different things. So we need to identify who the key stakeholders are, engage with them early, and have a continuous engagement throughout the implementation period. The formation of the HIV self-testing steering committee also is very important. This committee that we have in Zambia is a subcommittee of the HTS technical working group. It provides program direction. How does Zambia actually envision HIV self-testing going forward? It coordinates across different partners to make sure that the lessons that I learned by one partner can actually be used by another partner as they come on board. And also it provides a platform for the development of national HIV self-testing operational framework. The guidelines, the HTS guidelines currently do have HIV self-testing, but I think we need a more comprehensive framework. So we have already started discussing that at the HIV self-testing steering committee, and different partners actually sit on this committee, implementing partners, as well as other stakeholders. We do need to broaden the stakeholder involvement in this committee, and I think in the next meetings that we'll have, we'll actually see a broader representation of partners. From the high numbers of test kits that we have actually distributed over an 8-month period, 96,000, we would actually say there is a high acceptability. We've actually been inundated with requests to scale up self-testing to other areas. And also we have people come through to our offices to actually ask for self-test kits. So people are actually eager to have this program out there. It is possible to implement HIV self-testing within a public sector setting and actually take it to scale. And it reaches various populations. HIV self-testing uptake is high amongst men, 50% of the population. Of the acceptors of self-test kits in Zambia were men, and about 47% were young people. So we are reaching the young people, but I think we need to have more targeted approaches to actually reach more young people as well as more men. We have not reported or recorded rather any adverse events associated with HIV self-test kit distribution. At the beginning, during the stakeholder engagement, one of the things that always came up was there is no counseling that is actually going on with HIV self-testing, and therefore, how sure are you that people will not actually be killing themselves? I think the evidence prior to the onset of STAR showed that that is not likely to happen, and I think we've actually seen in STAR as well that no adverse events have actually been recorded. As we move forward, in addition to the models that I've spoken about, we do need to think of complementary models of distribution. In as much as we have a health facility model, I think there is some level, we can actually improve on that. Currently, this model is parallel in that we have someone stationed there that's distributing test kits. I think as we move forward, we want to see a more integrated health facility model. We have community-based models, but we're not reaching key populations specifically in this project, so that's something to actually think about. And then also distributing through workplaces to reach more of the men or the people who don't have the time to go to these health facilities because they're working, and through pharmacies, because I think it's important we actually reach everyone that is in need of a self-test kit in using a channel that actually fits them best. As I end, I'd like to acknowledge several people. Firstly, the Minister of Health. I think they have been the key stakeholder in the implementation of this project. I would also like you to acknowledge the funder as well, UNITAID, for making this possible, and the PSI family as well as the STAR family as a whole. We would not have done this alone, so thank you to everyone that has actually made this possible. Thank you.